Good morning, Dr. J. My name is Emerson. I'm your student nurse practitioner assigned to this patient in room 1. Her name is Annette Stark. She's a 78-year-old female who came here because of shortness of breath and acute respiratory symptoms, which is accompanied by a new onset of coughing and yellow thick purulent sputum and shortness of breath with difficulty of breathing, tired and run down, has been run down, started 24 hours ago while changing her life valve uh, in her driveway. There's her albuterol, prescribed albuterol was not able to like relieve her symptoms. She nothing may what makes it worse is that whenever she does some activity, she's becoming more short of breath, and that prompted her to come here to be admitted, and she's unable to like take full breaths, and um uh and she said that this is one of the worst kind of like shortness of breath that she has had since she had a diagnosis of COPD. She has history of COPD and osteoarthritis, and she's taking medications such as albuterol inhaler, Singulair 10 milligrams PRN, Lortab 10 over 325 PRN, and she's taking also naproxen for pain, for her osteoarthritis, 5 milligram PO daily PRN. She has no known drug allergies. Uh, Her family history that is like really pertinent is that her mother died from COPD at age 80, and also her mother has a history of hypertension. That her dad passed at 68 years old from diabetes. She lives alone and she's a retired tax accountant. She has been like smoking for the past 55 years, and she has no plans of quitting even though I offered medications or anything that could help her, at least quit smoking. With regards to her review of systems, I will just be telling you the pertinence and positives we're in. She just looks tired and weak for me, and she has difficulty of breathing, and this is, of course, I told you earlier that it is not unrelieved with albuterol inhaler. She has orthopnea, paroxysmal nocturnal dyspnea. She had wheezing, according to her, and she's been coughing out with yellow thick sputum. She had history of 2 pregnancies and no 2 miscarriages and no live births. She said that the last self-breast examination was like 3 years ago. No mammogram was done. She has knee pain and joint pains whenever she starts her day and waking up. With regards to her physical exam, her weight is 130 pounds, and her height is 5'5". Her BMI is 21.6. Temperature is 98.9. Pulse is 90. Blood pressure 140/70. Respiration 20. 90% at room air. She's very, with regards to his like appearance, she's alert oriented, responds appropriately, and is in clean clothes. She has a small to medium body uh, build, and she's well nourished, adult female with normal mood and affect. Um, Skin is normal, head, ears, nose is normal, cardiac is normal, respiration. Upon auscultation, I can hear some like and inspiratory wheeze, and wheeze on auscultation, and her AP diameter is 2:2. She has limited range of motion whenever with her knees, but according to her, this one improves as days goes by. The labs that are normal are the ABG. ABG is normal. CMP, CBC, CRP are normal. AKG is sinus tachycardia, although on telemetry that's in her room, it says that it's just sinus rhythm. Chest x-ray was initially done, and it says that it's bilateral hyperinflation, and I think this is evident because she has history of COPD, and she has like fine effusions bilaterally, and I think this is the cause of her coughing. um, I ordered for anti-1 antitrypsin. It's still pending lab draw because I want to know if her COPD is partly caused by genetics. CT scan with contrast resulted with emphysemic changes with bilateral lobe atelectasis. So with that result from CT scan, my differential diagnosis for this patient, and the number one diagnosis I have is emphysema and COPD. I have asthma. Asthma is gonna be ruled out because there's no like allergen that triggered her to have this symptom, and she was not wheezing really hard, and it's kind of like stridor kind of wheezing when she came in. So it will gonna be ruled out. Pulmonary embolism will gonna be ruled out also because um she doesn't have chest pain. She only has shortness of breath. Usually with pulmonary embolism, they are really short of breath and sometimes like in respiratory distress. So this diagnosis will gonna ruled out. Congestive heart failure will gonna ruled out because she doesn't have any jugular vein distension. She's not fluid overloaded, no edema. So those are the ones that ruled out. Basically the management for her that I have, like I have my plan for her is to give some SAMA, LABA, ICS, antibiotics, and just like educate her. But with administration of the SAMA, LABA, and ICS, inhaled corticosteroid or intravenous corticosteroid, I want to like check their FEV1 and FVC before and after giving the medication, so that I will know which ones are the one that is helping her more, and make sure that her pulmonary function has improved. Of course, give her some spirometry instructions, care of respiratory therapist. For my SAMA, I'll be giving albuterol. For my LABA, be giving salmeterol, discus, and then for my inhaled corticosteroid, I will gonna start with budesonide inhalation. But if she will not improve with that, I'm gonna be giving her some methylprednisolone 125 milligrams IV once, and then I'll gonna be tapering it just to like help her with her breathing. Since she has a COPD and she's a former smoker, the 2024 gold initiative recommends that she will gonna be administered with antibiotics, and I choose azithromycin 500 milligram once daily. And also I'm gonna be giving some educations for this patient regarding stopping smoking cessation, use of supplemental oxygen at home or even inpatient, health promotion with regards to like proper nutrition, exercise, probably use of nicotine patch inpatient while she's unable to like smoke because of her illness. Also give her some vaccinations to prevent and reduce exacerbations and infection. And my plan for her is to like stay in the ED for the next 24 hours or admit her to a observation unit. So with regards to her osteoarthritis, of course, I'll just continue her medications for her pain, like the naproxen and Lortab. And for the shortness of breath, of course, like, just supportive uh, medications and treatment um, for her symptoms. Uh, I would assume she will gonna be discharged tomorrow if she improves rapidly, but if she's still decompensating, I think she's gonna stay for another 1 to 2 days. I think that's all I have for you. If you have anything to add, please let me know so I would know and learn how to manage COPD and emphysema. Um, and I think that's all. If you have any more questions, please let me know. Thank you.